Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture series number 54, that is the neoplasms of the kidney, and the nephro-blastoma, that is the Wilms tumor. In this lecture we will learn the malignant neoplasms, that is the renal cell carcinoma, staging of the tumors, and the nephro-blastoma, that is the Wilms tumor. Let's start the neoplasms of the kidney. Classification: tumors of the kidney may be divided into tumors of the kidney proper and the tumors of the renal pelvis. These are the two types. First, we will see the tumors of the kidney proper. These are the further subdivided into benign enlargement and malignant neoplasm. First is the benign tumors. From the classical standpoint, benign tumors of the kidney are rare. These tumors may occur in the epithelial tissues, connective tissues, and in the perinephric tissues. Benign tumors are adenoma, haemangioma, carcinoid tumors, fibromas, lipoma, myomas, neurofibroma, angiomyolipoma, hamartoma, and endometriosis. Most of these tumors are 1 to 2 cm in diameter. Of these tumors, adenoma requires special mention. Adenoma is probably the most common benign tumors of the kidney. It is 3 times more common in the men than the females. And the next is the angiomyolipoma, that is the hamartoma. Obviously, it is a very rare tumor of the kidney. The tumor has got all the elements like excessive blood vessels, muscles, elements, and excessive fat. It is very easily diagnosed on CT scan. It is interesting to note that the 1/4 of this tumor may turn malignant and may lead to metastasis, angiomyolipoma. Always remember. And the next entity in the benign tumors of the renal are the angioma. This tumor usually occurs in the young adult. The main complaint is profuse hematuria. One can easily diagnose this condition by the renal angiography. And now the malignant neoplasm, the tumors. These are mainly 2 varieties of these tumors. First is the Adenocarcinoma, which occurs in the adults usually above the age of the 40 years and constitutes 4 to 5 of all renal neoplasms. Next is the Nephro-blastoma, which is exclusively a tumor of children, mostly occurs under the age of 4 years of age, average 1 to 7 years. Between the age of the 7 years and 40 years, malignant neoplasms of kidney are unusual. And third is the unusual variety, that is the sarcoma of the kidney, is extremely rare. Now first, Adenocarcinoma, that is the renal cell carcinoma. It is the commonest tumor of the kidney and constitutes about 80% of all the tumors. Etiology: the cigarette smoking, obesity, and use of the drug like phenacetin. A few chemical carcinogens have been identified. These are the dimethyl nitrosamine, diethylnigrotoamine, food additive, potassium bromate. Means potassium bromate is largely found in the bread. So dear friends, I advise you to avoid all types of the bakery products, junk foods which contains the potassium bromate, and these are the carcinogens for the renal carcinoma. Spread: local invasion, lymphatic spread, blood spread by embolism, by permeation. This is the CT image of the adenocarcinoma of the renal cell, clearly seen in this image. This is the another animated image of the adenocarcinoma, is clearly seen on the left side of the kidney. There is a cancerous part, that is the stage 4th kidney cancer. You can clearly see. Now the staging of the tumor. The tumor has been staged clinically to know the prognosis of the case. Stage 1st, tumor is confined to the kidney. Stage 2nd, that is the perirenal spread, is confined within the perineal fascia. Stage 3rd, the renal vein of inferior vena cava has been involved or local lymph nodes have been involved. Stage 4, advanced disease with distant metastasis. Use of ultrasonography, CT scanning, and measurement of the level of the tumor markers have been significantly increased the accuracy of staging of the tumors preoperatively. So tumor marker studies has been done. Dear students, here is the image on your screen showing the stage 1st, 2nd, 3rd, and 4th of the carcinoma of renal cells. Stage 1st, the tumor is 7 cm. In the stage 2nd, the tumor is more than 7 cm. That is the up to the gyrotous fascia and vena cava is clearly seen. And in the 3rd stage, adenocarcinoma is spreads up to the vena cava and up to the gyrotous fascia. And in the 4th stage, the renal cell carcinoma is spreads up to the another organs and the lymph nodes. There is a metastasis. These are the staging of the tumors. Now the clinical features: symptoms: painless hematuria, pain, swelling, persistent pyrexia, hypertension. General symptoms: metastatic symptoms like In case of the lung metastasis, persistent cough, hemoptysis, chest pain and dyspnea. In case of the bone metastasis, painful enlargement of bone, that is the pathological fracture, etc. In the liver metastasis, jaundice, ascites, etc. In the brain metastasis, persistent headache, nausea and vomiting, neck gland and swelling from the left supraclavicular lymph nodes, that is the Virchow's nodes. Now the physical sign, the local examination of palpable renal tumor is often a late sign, and by this time the patient nearly always has metastasis elsewhere. A fixed renal tumor is an even more than late sign. General examination, development of the dilated veins and abdominal walls, a left-sided sudden varicocele, arteriovenous fistula is occasionally observed. Metastatic signs may be seen in the late cases of the disease. Loss of weight is another general sign. Then the special investigations of these are the blood investigation, urine examination, X-ray, straight X-ray, X-ray radiogram, filling defect, elongation and distortion of the calyces, ultrasonography, base scan sonography diagnosis tumor with 95% accuracy, computed tomography, CT scan should be done, isotope scanning, bone scan, urinary cytology and tumor marker study should be performed. Now the treatment of the renal cell carcinoma, adenocarcinoma. The definitive treatment of the primary renal cell carcinoma is radical nephrectomy. In the group first includes cases where there is no demographable metastasis. These cases are suitable for radical nephrectomy, including removal of the fat and renal lymph nodes around the kidney. Group second includes cases where there are no demonstrable metastasis and the tumor is too fixed to allow nephrectomy to be performed. Inoperable cases. Treatment of these cases is palliative X-ray therapy with or without chemotherapy. Group third, this group includes adenocarcinoma of kidney which is resectable with a solitary metastasis. The treatment of this group is radical nephrectomy with excision of the solitary metastasis, be it lobectomy and pneumonectomy for lung metastasis or amputation for the bone metastasis if there. Then the group 4, there may be bilateral tumors of adenocarcinoma in only remaining kidney. In these cases, partial nephrectomy should be considered with removal of adjacent perirenal fat and renal lymph nodes. Now the chemotherapy, the use of the fluorodeoxyuridine, that is the FUDR, which has produced almost some response, whereas vinblastine attempts to improve the response rate by combinating cytotoxic agents have not been very successful. Now the hormone therapy, medroxyprogesterone acetate, that is the MPA, is proved to be the standard hormonal therapy treatment for advanced renal cell carcinoma. The drug given at the dose of the 300 mg per day, that is the Bloom's report. According to the Bloom's report, progesterone after than MPA seems to be less active. Tamoxifen at the low dose appears to be virtually inactive, but it given at the high dose 800 mg per day, it has shown some response. Combination of hormones with chemotherapy does not seem to have anything to add to the response rate. Next is the immunotherapy. Interleukin 2 is a cytokinin which was first identified as a T cells growth factor, but has since been shown to have a variety of effects, including stimulation of macrophage cytotoxicity, stimulation of beta cell growth and production of other cytokinins, that is the interleukin 2 stimulated T cells, that is the LAK, has been used as a immunotherapy combined with intravenous interleukin 2. Now the next point of this lecture is the nephro-blastoma, that is the Wilms tumor. The tumor was first described by the Ryans in 1815 in London and then in Scotland by the Gerner in 1828. Wilms first gave a comprehensive description for this tumor in 1899, but suggested that the tumor arises embryologically from undifferentiated cells in the Olffian ridge. The tumor is also called embryoma or adenomyosarcoma. Incidence: it is highly malignant mixed tumor. It is almost exclusively a disease of children under 4 years of age. Pathology: this tumor may develop in any part of the kidney. The majority present as a single expanding tumor surrounded by a pseudocapsules of connective tissues. Sometimes the tumor may appear juxtarenal, but it is usually attached to the kidney with a small pedicle. Occasionally, the tumor may be multiple separated nodules spread throughout the renal parenchyma. Now the spread, direct invasion. This is the major type of the spread of this tumor. The tumor gradually invades the kidney and later on the neighboring organs such as the kidney, spleen, colon, adrenal glands, diaphragm and the posterior abdominal muscles. Renal capsules, however, remains intact for a long time, so that invasion of the neighboring structures are comparatively rare or comparatively late. Next spread is the lymph spread. This is comparatively rare. Through regional lymph nodes are frequently enlarged. At operation, these glands on section usually show simple hyperplasia without evidence of the secondary tumor. And third is the blood spread. By the bloodstream are not frequent, though blood spread to the lungs is the commonest site. This spread may occur to the vertebrae, liver and to the opposite kidney. Dear friends, here is the image showing the Wilms tumor, that is the nephroblastoma. This is the typical clear picture, animated picture of the Wilms tumor, nephroblastoma of the kidney. This is the nephroblastoma. Now the clinical staging of the tumor. Stage first, tumor is restricted to the kidney. Stage second, tumor extends beyond the kidney but within the perinephric tissues and it is resectable. Stage third, the tumor spreads beyond the perinephric tissue and is not completely resectable. Stage fourth, with hematogenous metastasis. Step fifth is the bilateral tumor. Now the clinical features. Symptoms are the most common presentation is a palpable mass in the flank, usually discovered by the child's parents. Second is the abdominal pain, which is rather vague and ill-defined, may be seen in the 2/3 of the cases. Hematuria, in fact, no hematuria is seen in the 70% of cases. Pyrexia is seen in 20% of cases. Now, the special investigation has to be done in this Wilms tumor or nephroblastoma are the blood investigations. Polycythemia may also be associated with these tumors, presumably due to the raised erythropoietin level. Next is the X-ray, straight X-ray, extraordinary urograms. Chest film may disclose metastasis in the lungs. Inferior vena cavogram. Selective angiography may be useful if the diagnosis is still in doubt after extraordinary urography. And third is the ultrasonography and CT scan are helpful in diagnosing this tumor. Radioisotope scans, tumor markers. This is not very specific tumor markers for the nephroblastoma. Now the treatment. It has been generally accepted that the nephroblastoma requires a combined program of surgery. That is the surgery, radiotherapy and chemotherapy. Surgical treatment of this condition is radical nephrectomy with excision of the perirenal fascia and renal lymph nodes. Second is the radiotherapy. Only when it is judged that the tumor is too large to allow nephrectomy to be performed. Preoperative irradiation should be administered. Doses of 500 to 1500 rats are given to the patient, which have considerably reduced the bulk of the tumor. The purpose of the postoperative radiotherapy is irradiation of residual tumors. This is particularly given when the tumor is invasive and there are lymph nodes metastasis. The dosage of the radiation depends on the equipments. If cobalt-60 is used, this is given in 5 or 6 fractions a week to a dose of the 1000 to 1200 rats per week. Hepatic metastases are also eradicated with combination of the chemotherapy. Now the chemotherapy in the nephroblastoma, the primary role of the chemotherapy is to destroy the disseminated disease. Chemotherapy may be given preoperatively to shrink the massive tumors to the resectable size, up to the resectable size. Chemotherapy has an important role to play in palliation when radical nephrectomy is not possible and a portion may be left behind. Actinomycin D and vincristine are most effective drugs are commonly used against nephroblastoma. Next point, tumors of the renal pelvis are usually epithelial tumors and can be divided into 3 groups. That is, the first is the transitional cell carcinoma, second is the squamous cell carcinoma and the third is the adenocarcinoma. All these should be treated according to its stage and the types of the tumors. Now the next point is the laparoscopic nephrectomy. This operation was first carried out by the Clayman et al. In 1991. The procedure is a complicated one and should not be undertaken by the inexperienced laparoscopist. Indication: this technique is probably most useful for the removal of burn on glomerulonephritis or pyelonephritis kidney, the burnt out stone kidney where there has been perinephric inflammation. First type is the transperitoneal approach. The patient is placed on the operating table. As far as the open renal surgery, endoscopic access is obtained by a 10 mm umbilical port and port placed about 5 cm lateral to the midline in the plane and umbilicus towards the side of the affected kidney. 5 and 12 mm ports are placed in the mid-clavicular line and 2 further 5 mm ports are placed in the mid-axillary line under the right vision. The dissection is connected, commence incising the posterior peritoneum along the line of the torts lateral to the colon from the hepatic and splenic flexure depending on the side down to the iliac fossa. The colon is displaced medially and the ureter is visualized in the retroperitoneum. The ureter is dissected and divided at the level near the iliac vessels. It is followed upwards till the renal pelvis is exposed. Dissection is now carried out and the pelvic ureteric fat is to reveal the renal vessels entering the hilum anterior to the pelvis. 1 cm length of the each vessel is dissected free. The vessels are now transected and divided with the endoGI clamp passed through the 12 mm port. This instrument placed 2 rows of the staples across each vessel and divided the vessels automatically between the staples. The kidney is now gradually dissected from the surrounding perinephric fat and fascia. The kidney is thus mobilized through the 12 mm port and is specially made impermeable sac is introduced into the peritoneal cavity. The margins of the neck of the sac are opened with graspers and pass through any of the 3 lateral ports of 5 mm. The kidney is manipulated into the sac and drawstrings at the neck of the sac is pulled and the neck of the sac is withdrawn through the enter of 10 mm or 12 mm port. On the surface of the neck is grasped by the 2 to 3 artery forceps. The kidney within the abdomen is fragmented with the commercial disintegrators and chopped up with a pair of the surgical scissors passed through the neck of the sac. The fragment of the kidney is then aspirated and the sac withdrawn from the abdominal cavity. In this way, the transperitoneal approach of the laparoscopic nephrectomy should be performed. And there is another way of the retroperitoneal approach. Here is the picture showing the sizes in the millimeter of the port 5 mm, 10 mm and 12 mm and the positions of the port used for the laparoscopic nephrectomy and the nephroureterotomy. Dear students, you can watch very good pictures of nephro-blastoma, videos of operations of the laparoscopic nephrectomy, ureteronephrectomy on the YouTube. You can watch it to clear your concepts. And here is the end of our surgery lecture number 54. That is the neoplasms of the kidney and the nephroblastoma, that is the Wills tumor. Thank you.